Okay, so the difference between Hodgkin and non-Hodgkin's lymphoma, well, firstly, the similarity is they're both types of cancer and lymphoma, but the difference is that when we take specimens from them, they have different appearances under the microscope and different, if you like, features and molecular changes. Also at a clinical level, as in how the patient is affected, they can be slightly different too. Non-Hodgkin lymphoma is a very diverse group of disorders, from very indolent or low grade diseases that, if you like, bumble along and actually may not adversely impact the patient physically, and to far more aggressive, rapid presentations that may make a patient unwell if not treated promptly. So there are a very diverse population of disorders, the non-Hodgkin lymphomas, whereas the Hodgkins are a sort of smaller cohort and less common set of disorders. Can present in similar ways, but the non-Hodgkin lymphomas are very diverse. So symptoms for non-Hodgkin lymphoma, most commonly they do present with lumps. So, and that again is lumps in the body, typically in the neck, the armpits, or the groins, because that's where we have our lymph nodes that we can feel. We've got lymph nodes normally throughout our bodies, but these are the areas we might notice first. And if the non-Hodgkin lymphoma, that is a type of cancer, involve these, then that process of cancer, of sort of unregulated growth of the cells, can lead to increasing size of the nodes and presentation as a lump. They can cause sweats, fevers, and weight loss that's unexplained. So patients may be losing weight or having sweats at night. They may also affect any area of the body. So they may affect the skin, they may affect inside the body, and patients may present with symptoms in the chest, sometimes a cough or breathing issues, or in their abdomen, their tummy, they may have symptoms there because of the site of that lymphoma affecting different bits of the body. So non-Hodgkin lymphoma diagnosed typically with what we call a biopsy, and that's when we take a solid specimen from what we hope is a representative site of what we think might be lymphoma, or another cause of a lump, of course, because not all lumps are lymphoma. But yes, it's critical to have what we call a biopsy specimen, and to emphasize that the earlier patients present with their lumps and the earlier we get the chance to take a biopsy for diagnosis, we firmly believe that the overall for our patients, that the earlier we can give treatment, and then the better outcomes we will have. So while a lump or a mass biopsy is typically the upfront diagnostic aspect, the way we do that can vary. Ideally, we will ask for a sort of surgical excision biopsy, which is a mini operation, but realistically, and certainly in my practice and most of my colleagues, we tend to use core needle biopsies. So if you can feel and see a lump that is safe to do, we will have a radiology colleague with an ultrasound probe with numbing agents, local anesthetic, take some slivers of tissue, core biopsies, we call them, with a special needle of a visit to the hospital. They can go home the same day, and then within a week or so we get results, and that can give us diagnosis, and that's a far more tolerable process for the patient, of course. For the laboratory colleagues of mine, it's a less specimen, so while better for the patient, it's sometimes harder to diagnose, so sometimes we ask for a second biopsy in these situations to make sure, and this is a challenge, but a solid tissue biopsy. We may also do a bone marrow test. That's less common nowadays because we generally get the diagnosis from a mass. We sometimes interrogate the blood, so blood tests can actually occasionally, not often, but occasionally reveal certain lymphomas and relatives of lymphomas. And we may need to take some other specimens from different bits of the body less commonly. So the non-Hodgkin lymphoma certainly can be treated. How it's treated is in a myriad, many different ways. A number one thing to consider is we are very pro trials. So clinical trials, they're the way medicine advances. That's the way we have treatments now from over the years, trials building up the way we can improve and develop treatments and management of our patients. So we will always, if possible, consider and offer a clinical trial. Patients are not obligated to go on a trial, but we strongly encourage them to at least consider that. Many cases of non-Hodgkin lymphoma may not need treatment. So whilst we tell a patient they have a cancer, if that cancer is what we'd call an indolent or low-grade non-Hodgkin lymphoma, as opposed to one of the more aggressive ones, there is a reasonable chance up front that we may say, actually, we can pursue active monitoring, which is a surveillance program. It used to be termed watch and wait. We now call that process active monitoring, and it does not involve treatment. At some point in future, that patient may need treatment, but initially often it's safe and appropriate and doesn't impact anything like survival, for example, if we adopt that approach. To be fair, most non-Hodgkin lymphomas eventually either need treatment immediately or after some time, and that treatment can be diverse. There are various different types. Antibiotics can actually cure certain types of lymphoma, particularly in the stomach. Well-tolerated, effective chemotherapy is used across many different lymphomas. Immunotherapy, which is typically has been recently monoclonal antibodies, which are, if you like, factory-made antibodies similar to what we produce ourselves to fight infection. These are produced to fight the cancer that can be given to patients. Radiotherapy has a role to play in many types of non-Hodgkin lymphoma, and these different combinations of these treatments can be utilized across different subtypes of non-Hodgkin lymphoma. Novel therapies, new therapies coming through include sort of targeted molecular therapies, and there's using cellular therapies. So sometimes patients need something called a transplant that can be from themselves to support high-dose chemotherapy to eradicate a lymphoma, or from a donor to try and get rid of a resistant lymphoma. And there are novel therapies such as CAR T, chimeric antigen receptor T cells, that are increasingly used and have become a standard of care in certain sort of relatively uncommon scenarios, but are proving very effective. So there's many different treatments that do have side effects, but which we can manage very well. So the treatments we can apply are effective overall and can be managed so they are generally tolerable to patients. So non-Hodgkin lymphoma is a very diverse group of disorders. There's many dozens, over 60 different types of non-Hodgkin lymphoma, but treatment is increasingly effective. There are very different treatments for different types of lymphoma, but generally they're very effective for most lymphoma. The different types of treatment are applied, but and sometimes we do need more than one treatment. Certain types of lymphoma have a sort of history of waxing and waning, being treated, going away, coming back again. But that may be measured in years and actually in decades for some of the indolent lymphomas, whereas the more aggressive ones are curable. The more indolent ones we generally term incurable, which sounds dramatic, but actually that statement incurable, if a patient is well without the disease causing symptoms or problems, and either not needing treatment or responding to treatment for years or even decades, then whilst technically uncurable, it may not impact their quality of life, and hopefully enable them to function very well, and hopefully forget about people like me in between appointments.